My name is Danielle Roman. I am a clinical pharmacy specialist and manager of clinical pharmacy services at Allegheny Health Network in Pittsburgh, so the rival institution to Dr. Fancher, who just presented. So I don't know if you've been paying attention to the agenda, but you may have noticed that we have the remainder of the afternoon together. So this is quite the marathon session in breast cancer. And very candidly on my end too, breast cancer is a really challenging topic to feel like you have a good grasp of. There's so many different nuanced parts of practice, and that only seems to grow year after year, hence the 2.5 hours talking about just this topic alone. So my hope for you, you may not feel like an expert at the end of this time together, but my hope for you is that you feel like you have the tools to be able to help navigate some of this a little bit better, and just really to get some of those foundations of practice. And for those of you taking an exam on this, really just to be able to apply some of what we're learning today to patient cases. So we use a lot of cases throughout to try to emphasize some of these important topics. We're going to highlight from a learning objectives perspective, we're really going to highlight, again, treatment decision making and how to apply those to patients. So there are a lot of other aspects of breast cancer that we're not going to discuss here today. So things like screening, prevention strategies, we'll do a little bit of survivorship, but there's a lot more to that. So definitely things that are important to know about that are included more in the extended, the handout version. Our time today is really going to be focusing on treatment options and treatment decisions for patients. So we're going to break this down. We're going to have really 2 parts to our discussion today. In between those 2 parts, we're going to do a 5-minute stretch break so I can rest my voice a little bit. You guys can stretch a little bit so you hopefully don't fall asleep on me. So things like that. So I'll announce that time together. We'll give you 5 minutes to stretch. We're going to use the first part of our time together to focus in on early stage and locally advanced breast cancer. So stage 1 through 3 patient that we're trying to cure them of their disease. So we're going to talk through that, as well as cardiotoxicity, which is a really important supportive care topic with our patients with breast cancer, and even expanding into other cancers as well. So again, there's a lot to breast cancer. If you have seen the NCCN guidelines recently, we're up to almost 250 pages in NCCN alone. And then, of course, we have ASCO. So ASCO and NCCN are sometimes in agreement about things, sometimes not in agreement about things. And then ASCO has over 20 separate breast cancer guidelines out there. So this attempt is to summarize that for you. So hopefully you get a sense of that as we move through today. Within early stage breast cancer, there's really kind of 2 big buckets of treatment strategies. There is the strategy of our local therapies. So things we're really not going to focus in on today, but are super important to treatment. So things like surgery and radiation for our patients. So that is going to be a component of treatment for all of these patients with early stage disease. And then we have our systemic therapies. So here's where we're going to talk about a lot of the nuanced strategies and what comes into play from a pharmacist perspective with treatment decision making. So talking about things like chemotherapy, our targeted agents, so a lot of this having to do with HER2 targeting agents, but we have more than that now. And then also talking about our endocrine therapy strategies in breast cancer. I think one of the more difficult things in breast cancer is just how to sequence all of what we talk about today. So that's what this slide is, an attempt to kind of put us a kind of big picture of how to sequence these therapies, and then we'll talk about each of these different treatment modalities in a bit more detail. So just walking through a patient with early stage breast cancer. So here we're really talking more probably in the stage 1-2 treatment setting where patients are deemed to be resectable. Okay, so surgery being the frontline approach to what is happening for most of these patients. If chemotherapy is needed, and we certainly will talk about when that is, if a patient needs that, it's going to be following surgery, typically. And if they need a HER2 targeting agent, that's going to probably happen at the same time you start your chemotherapy, and then continuing on usually for a year Patients that require radiation, this is going to be after the completion of chemotherapy. For patients that need endocrine therapy, there's kind of two different schools of thought here. One is that you can start it after the chemotherapy at the same time as radiation, or you can have the patient complete chemotherapy, complete radiation, and then start their endocrine therapy course. So we're talking about really long courses of therapy for these patients after their surgical resection. So either of those approaches of endocrine therapy with radiation or after radiation can be appropriate based on guidelines. One of the providers I work with really tends to want to start that after radiation just because of some concerns with potential additive effects there, side effects. And then we'll talk about the subset of patients that may require some additional therapy with a PARP inhibitor, olaparib, and that would be following radiation. So there is a whole kind of scheme here, but just to put it all in one page for you, we'll talk about each of these strategies in a bit more detail. So with that local therapy strategy, so just a couple things to mention here from our standpoint. When we talk about surgery, we're typically talking about patients that have a lumpectomy. This is also known as a partial mastectomy. So those two terms generally equating the same thing. So this could be an option for patients based on size of tumor, patient's desires for therapy, and generally a decision that's being made by the surgeon. The other option here is complete removal of the breast tissue with a mastectomy. Radiation therapy can also be used here. If a patient has a lumpectomy, generally radiation therapy is going to be included in their treatment strategy. So after some point after their surgery, radiation would be involved. If the patient has had a mastectomy, radiation in this setting is generally only in patients that have some higher risk features, such as lymph node positive disease, or if they have a surgical resection where the margins are positive or close. One of the, I would say, changes in breast cancer that has really changed the field in the last 10 years has been the use of gene expression assays. So name of the game here is de-escalating therapy. So the historic thought was more is better, right? And that was the case in a lot of different cancers, but in particular in breast cancer, it has been, can we peel back on some of that for these patients that are curative intent, that could potentially have long-term toxicities from what we're doing, and can we give less but still get those same good outcomes? The one way of doing that is with gene expression assays. So this is a way, thinking back to pharmacogenomics course, of providing prognostic information about the cancer itself and predictive information about therapy to make some of these decisions for patients and whether or not they need to receive chemotherapy. These tests are standardly recommended for a certain subset of patients that happens to be the majority of patients with breast cancer. So this is patients with early stage disease, which we know is over 90% of our patients are diagnosed with early stage disease, which is great. So a lot of them are going to be candidates for this. Also, these patients have to have hormone receptor positive disease, which is, again, the majority of patients. HER2 negative disease, so all things that you would find on a pathology report. And either patients that don't have any lymph node involvement or with low levels of lymph node involvement, so 1 to 3 lymph nodes that are positive. So this is really, again, this is the majority of patients that fit into this category, but it's a very specific group of patients where this is indicated. It is not indicated currently for patients that have triple negative disease, so those patients that are hormone receptor negative, HER2 negative. It's also not indicated in patients that have HER2 positive disease. So if patients overexpress HER2 on their pathology report, they're not candidates currently for this testing. And then also if they have higher volume lymph node positive disease. So if they have 4 or more positive lymph nodes, generally those are going to be patients that are candidates for chemotherapy, so we wouldn't be doing this testing. There are a number of different testing available for this, so different assays out there that you can see listed here. The two that we're going to talk about that really have more of a place in guidelines at this point are the Oncotype DX testing and MammaPrint. Oncotype DX, a very commonly used gene expression assay. It's quantifying the likelihood that breast cancer will come back. and also the benefit of chemotherapy. So it's been validated in both of those settings. Again, for patients that meet that criteria, early stage, hormone receptor positive, HER2 negative. And it's using PCR methods to measure the expression of 21 genes. Some are related to cancer and some aren't. And it's testing kind of normal against a patient's tumor sample. This could be from a biopsy result. Could also be from a surgical specimen. Based on that analysis of the tumor sample, patients are assigned a recurrence score. That could be anywhere from 0 to 100. So lower is better. The higher the score, the higher the risk that the cancer could recur in the future, and therefore the greater the benefit of giving patients chemotherapy. So one of the key trials that's really helped us with decision making on what to do with this RS or recurrence score is the TAILOR-X trial. So you'll see numbers here much greater than what we tend to see in oncology trials. So over 10,000 patients enrolled in this trial with that kind of core patient population we were talking about before. So hormone receptor positive, HER2 negative, and this specifically was in patients that did not have any positive lymph nodes. They were assigned a recurrence score based on the Oncotype DX test, and then for there were assigned into a risk category, so anywhere from low, intermediate to high, and you'll see the corresponding recurrence scores there. So that low risk group was not a randomized part of the trial. That low risk group was assigned to get endocrine therapy only. So if you had a recurrence score of 10 and under, you got endocrine therapy only. If you were in the high group, so if you had a recurrence score of greater than 25, you were also not randomized. You got chemotherapy and endocrine therapy. So when we do this strategy, chemotherapy, going back to our sequence side, chemotherapy is first, followed by endocrine therapy. And if the big question with this trial was that intermediate risk group and what to do with that intermediate risk group. Do they have to get chemotherapy, or can we spare these patients from chemotherapy? And so they were randomized to endocrine therapy alone or chemotherapy followed by endocrine therapy. So the first report that came out of this trial was looking at that low-risk subset that had endocrine therapy alone. And 9 years of follow-up, these patients have done extraordinarily well without chemotherapy. So really just further showing that chemotherapy is not needed in patients with a recurrence score of 10 or under. That intermediate risk subset was reported out next. And remember, this was really the question of the trial here. At 9 years of follow-up here, endocrine therapy was non-inferior to the combination of chemo and endocrine therapy. So you can see your hazard ratio of 1.08, showing that endocrine therapy alone is an acceptable option for patients in this intermediate risk group. Okay? So with recurrence scores up to and including 25, endocrine therapy is okay. We don't need to add chemotherapy for the majority of these patients. There was, however, as in breast cancer, we said there's lots of nuanced things. There is a subgroup analysis here that did show for women that are less than or equal to 50 years of age, so younger female with a recurrence score kind of on the upper end of that intermediate range, so 16 to 25, so kind of a higher risk patient population. There may be a benefit for chemotherapy. Okay, so there is a subset to consider there. They do have, with the exception of those in the recurrence score of 16 to 20, and a low clinical, kind of determined clinical risk by a provider. So it was pretty straightforward in the first analysis. The subgroup analysis has made it a little bit more challenging to interpret some of that. But basically, I think what you just keep in mind here is that for women less than or equal to 50 with a recurrence score that's kind of borderline, intermediate to high, those might be a patient population where you would want to consider adding chemotherapy. There might be a benefit there. The second big trial with Oncotype DX is a slightly different patient population. So another large trial, here we see patients that had that low volume lymph node positive disease. So 1 to 3 positive lymph nodes that previously positive lymph nodes was chemotherapy. So this was looking at, can we spare that group from chemotherapy and kind of long-term adverse effects of that. So randomize those patients to endocrine therapy alone versus the addition of chemotherapy to endocrine therapy. And what was saying here at the 5-year follow-up is that postmenopausal women had no benefit for the addition of chemo. Okay? So menopausal status matters. So we need to know recurrence score, but we also need to know something about the patient's menopausal status. Okay? So those patients had no benefit from the addition of chemo. They can be spared chemotherapy. But again, for those patients that are younger age, so a premenopausal woman, did have some benefit for the addition of chemotherapy. Okay? So that is, again, where we're going to consider that adding chemotherapy with their endocrine therapy. Okay. So there's really 3 big trials here. We've covered 2 of them with Oncotype DX. The third big trial with the gene expression assays is the MINDAC trial. And this was with a different assay. This is with MammaPrint assay. So again, another large trial, same general patient population that we talked about earlier. One of the differences here, though, is that they randomized patients that had lymph node negative disease and patients that had low volume lymph node positive disease. So instead of the 2 separate trials with Oncotype DX, we kind of have them all in one trial here with MINDAC. They broke patients down based on looking at 2 different things, genomic risk and clinical risk. And they used the MammaPrint test to find the genomic risk. They used something called Adjuvant Online, which is currently not available, but they used that particular prognostic scoring to see a patient's clinical risk disease. And so they used those 2 different criteria to match up patients. And what they really were focusing in on are patients that had high clinical risk. So providers probably would have given them chemotherapy based on those high clinical risks, but had a low genomic risk coming back from this MammaPrint test. So it was sort of, can we trust this test to guide decision-making, kind of overriding our instinct to give chemotherapy based on these high clinical features. 8 years of follow-up here. All patients, you can see that there really isn't a difference, a major difference in these 2 groups. So 92% with the addition of chemo, versus a little over 89% for patients without chemo, hazard ratio of 0.66. So this was deemed to be no real benefit for the addition of chemo overall for patients. That was also true for patients that the subgroup that had positive lymph nodes, 1 to 3 positive lymph nodes, really deemed to be no major clinically significant benefit of adding chemotherapy here. So similar to the results we saw with the Oncotype DX testing. So again, though, subgroup analysis, patients with age 50 and under, here was where there was a chemo benefit. So these patients, about a little over 93% compared to 88.6% without chemo, and this was deemed to be a significant clinical benefit with chemotherapy. And so this is the subgroup that probably does need to receive chemotherapy. Okay. So we're going to continue to move on, frame some of this treatment decision-making in regards to patient cases. So we'll start with the first ARS question, JH, 39-year-old premenopausal woman with ER positive, PR positive, so estrogen receptor, progesterone receptor positive disease or hormone receptor positive, HER2 negative, lymph node negative disease, early stage breast cancer. She has a recurrence score of 26. What is the most appropriate adjuvant therapy for JH? Is it A, anastrozole, B, chemotherapy with docetaxel cyclophosphamide or TC, followed by anastrozole, C, tamoxifen, or D, docetaxel and cyclophosphamide, followed by tamoxifen? Okay, excellent. So a couple important things that a lot of you picked out here is this patient has a high recurrence score. So she's got some good prognostic features and that she's hormone receptor positive, HER2 negative. That's usually good prognosis. Lymph node negative, early stage, those are all good things. But she's got a pretty high recurrence score. So it's over 25, which we said kind of is that cutoff for high risk. So she's a candidate for chemotherapy. And then we want to follow it by endocrine therapy because she's hormone receptor positive. The key here, and we'll discuss this more, is the fact that the patient is premenopausal. And so that's what leads us to tamoxifen being her best option for that. So we're going to take a deep breath because some of these slides are pretty heavy here. This is NCCN heavy kind of stuff. It's hard to make it too simplified, but we're going to do our best to break it down. So there are several things that are really key to getting through these next slides with NCCN. And also ASCO, kind of consider things that need to be considered in treatment decision-making for patients. One of those is the size of the primary tumor. So that plays a part in these algorithms that we'll look through. Another thing is hormone receptor status, we've been talking about, HER2 status, menopausal status for patients that are hormone receptor positive, and then the results of any gene expression tests that are done are going to be important. So those are kind of the 5 core things that I think you need to know in order to be able to navigate some of this. Without that information, it's going to be really difficult, if not impossible, for you to make good decisions about how to treat a patient. So you'll see a common theme as we move through for the patients with really small primary tumors. So less than or equal to 0.5 centimeter tumors, you're going to see a lot of the word consider. So these patients aren't absolute requirements for any of these therapies, but could be considered based on provider-patient desire for treatment. Where we have the most data is patients that have tumors greater than 0.5 centimeters. And so here, this slide is specifically looking at patients that have hormone receptor positive disease, HER2 negative, and are postmenopausal. Okay, so those 3 criteria. For patients that have a tumor that's greater than 0.5 centimeters, either a little as a micrometastatic lymph node positive disease or low volume lymph node positive, so 1 to 3 positive lymph nodes. This is the patient criteria we've been talking about with using gene expression assays. So this is really where this is kind of the core of where this fits in for patients. And you'll see here NCCN references says the 21 gene RT-PCR assay. This is Oncotype DX. Okay, so without saying its brand name here, that's what they're referring to. So for patients that have, again, this is postmenopausal specifically, have a recurrence score of less than 26. So this was the low and intermediate groups of the TAILOR-X trial. And based on that trial, endocrine therapy alone is a good option for these patients. For those that had a recurrence score of greater than or equal to 26, so this was the high-risk group from that trial, that's when we're going to need the addition of chemotherapy to their endocrine therapy. And remember, it's chemo, complete the adjuvant chemo course, followed by their endocrine therapy course. If this testing is not done, we're going to err on the side of caution and probably give these patients a course of chemotherapy, but it's kind of a plus or minus in that decision-making. For those patients that have 4 or more lymph nodes, so higher lymph node positive disease, higher risk disease, these are going to be patients that should receive chemotherapy and endocrine therapy. So here, same patient population we just talked about, but now we're going to look at the premenopausal. So previous to this, last year when we presented this, it was really one big slide, but now we have this subgroup analysis coming out of trials telling us probably should be looking at this differently and breaking it down in pre- and postmenopausal patients. So this is our premenopausal patient population. Again, small tumor size, it's a consideration for endocrine therapy. For those patients that have at least or greater than a 0.5 centimeter, again, breaking it down on recurrence score. What you see is the recurrence score is different here. So it's a lower threshold. So for patients that have less than or equal to 15 as their recurrence score, endocrine therapy alone is sufficient. And we're going to talk about this OAS in a second. That's ovarian ablation and suppression. Okay? So that could be added for a premenopausal patient. For those that fall in that kind of higher end of intermediate range, chemo could be considered here in addition to endocrine therapy, kind of a plus or minus. And of course, those with higher recurrence scores, at least 26 or more, you're going to add chemotherapy to the endocrine therapy. So here, we're going to talk about slightly different patient population again. So this is patients that have lymph node positive disease. So same as the last slide, but we're adding in some criteria with lymph node positive disease. Low volume lymph node positive disease, 1 to 3 positive lymph nodes, and a patient is not a candidate for chemo, you're not going to give chemo to that patient. So endocrine therapy alone is fine. For patients that are candidates for chemotherapy, so probably the majority of this patient population, they're going to be candidates for gene expression assays, and then making our decision based on that last slide. So looking at their recurrence score and making a decision based on there. If they have higher volume lymph nodes, like you've seen a trend with the other algorithms, those are patients candidates for chemotherapy, followed by endocrine therapy. Okay. So switching gears slightly, so these slides look similar, but there's some couple important differences here. Now we're going to talk about patients that are HER2 positive, so patients that overexpress the HER2 protein, again, that we'll know from a pathology report. So trends here, and noticing that very small tumor, there's a consideration for therapy, so not an absolute. For those patients that have tumors that are 0.6 to 1 centimeters, this is going to be patients where they get endocrine therapy plus or minus chemo. So it could be considered based on patients' desires to be aggressive with therapy. If chemotherapy is given, these patients should also get a HER2 targeting therapy. So here in particular with trastuzumab that we'll be talking about in more slides. If chemo is given, they should also get a HER2 targeting therapy. And then where we have the best data for giving chemotherapy and endocrine therapy is in patients that have a tumor that's greater than 1 centimeter. So this was the core of all clinical trials with using trastuzumab. And these patients should get chemotherapy, HER2 targeting agent with trastuzumab, and then they're also going to get endocrine therapy after they finish their chemotherapy. So they're going to get all of those therapies following surgery. Okay. So now again, switching gears, and I promise we're getting to the end of some of these pretty heavy slides. So difference here is now we're talking about patients that are hormone receptor negative. So what you'll notice when you skim our options for treatment in these boxes is you don't see any endocrine therapy. Okay? So hormone receptor negative, we don't have the ability to use endocrine therapy for these patients. Okay? Again, very small tumor types, you see either no adjuvant therapy, or you can see consideration for chemotherapy, so kind of possibility to consider chemo and trastuzumab, but not an absolute for very small tumors. We get to tumor sizes that are 0.6 up to 1 centimeter. These are patients where if they're HER2 negative, chemotherapy alone, we can't use endocrine therapy, we can't use HER2 targeting therapy, so we're left with chemo. If they're HER2 positive, we're going to add trastuzumab to their chemo. So kind of the theme here, if you HER2 positive, we're adding trastuzumab to chemotherapy. Patients that are greater than 1 centimeter, HER2 negative, again, just chemo alone, and then those are HER2 positive, we're adding trastuzumab to chemo. So final slide here, promise, with these really heavy algorithms, is lymph node positive disease. So this is really everything except what we talked about in that limited group that was candidates for gene expression assay. So generally, patients with lymph node positive disease, this is more aggressive disease, they're going to be candidates for chemotherapy for the most part. Okay? So if you have a patient that's hormone receptor negative, HER2 negative, chemo alone, okay? Makes sense, no endocrine therapy, no HER2 targeting therapy. If they're hormone receptor negative but HER2 positive, this is where we can add in trastuzumab to chemotherapy. And you'll see a different targeting agent listed here. So pertuzumab also becomes an option in these lymph node positive disease patients. And we'll talk about how that got there, plus or minus. Okay? And then you'll see down below in the algorithm, hormone receptor positive, as you'd imagine. Now we're adding endocrine therapy to what we just talked about. So HER2 hormone receptor positive, HER2 negative, we've talked about that in previous algorithms. So that's part of what we already discussed. Hormone receptor positive, HER2 positive, okay, sometimes known as triple positive, we're going to be kind of everything. So chemo, endocrine therapy, and trastuzumab plus or minus pertuzumab. Okay, so kind of everything we've talked about is an option for these patients. Okay. So not a new algorithm. We're just going back to JH. We're just kind of showing where our patient fit in with what we've already talked about. So going back to her algorithm, hormone receptor positive, HER2 negative, postmenopausal patient, she actually fits in with endocrine plus chemo. Okay. All right, so we're going to use a little bit, the schema we're going to use as we move through some of the next slides to help chunk it out a little bit, kind of break it down. The first topic with systemic therapies that we'll talk about is endocrine therapy. Okay. Endocrine therapy choices, number one thing you need to know, making any decisions here, is you have to know the menopausal status of the patient in order to make a good treatment decision for patients. Okay. So for premenopausal patients, the primary source of estrogen is the ovaries. Okay. So we either need to use something like tamoxifen that's targeting at the level of the breast cancer cell, okay, to block the binding of estrogen to the estrogen receptor, or we have to use something that's shutting down the production of estrogen, and that's going to be primarily with the ovaries. Okay. So kind of standard of care in a premenopausal setting is tamoxifen. Okay. But we also have options of using things like OAS, so ovarian ablation or suppression. Most typically, this is done with LHRH agonists, so things like leuprolide, xarelin, triptorelin possibly. So things that are shutting down ovarian production of estrogen. And that's a reversible thing. Or when we say ablation, that can be things like radiation or surgical removal of the ovaries that can help to eliminate that source of estrogen. Okay. So now newer data in this setting is saying that you can use tamoxifen alone, historical standard, or you can add OAS to tamoxifen and then potentially even an aromatase inhibitor that used to always just be a postmenopausal thing. But now if you shut down the ovarian source of estrogen, you can actually add that to an aromatase inhibitor. Okay, so really three main options in that premenopausal patient population. Converse to that, so postmenopausal patients, they no longer have ovarian source of estrogen. Okay? So the primary source of estrogen production in these patients is the peripheral conversion of estrogens from androgens to estrogens. Okay? So one way of shutting that down is with an aromatase inhibitor. So it's shutting down the aromatase enzyme conversion that's happening in the periphery. So that is the primary agent that's used for postmenopausal women is an AI. There are also options for using tamoxifen. So tamoxifen is effective. It's acting at the level of the breast cancer cell. So it's able to be used in both a pre and postmenopausal, but seems to be some benefit of using AIs based on studies. So that is the preferred agent. Tamoxifen is an option, and then patients could also receive a combination sequentially of those two agents. In our premenopausal patients, so first look a little bit closer at that patient population. Most of these patients are going to get tamoxifen for at least 5 years. Okay? So that is standard of care, plus potentially adding in, we said, OAS for some patients. This could be considered, there's a footnote there, so you can consider adding OAS for patients with higher risk features. Okay? So younger age, a higher grade tumor that you would get on a pathology report, or potentially those that have lymph node involvement. So a little bit more aggressive with adding something like an LHRH agonist to the tamoxifen. If after 5 years patients remain premenopausal, there's a consideration to give 5 more years of tamoxifen, so doing 10 years of tamoxifen total. So it used to be you always did 5 years. It was really clear cut. Now not as much. You can do 5 years, but you can also do up to 10 years kind of based on the desire of the patients, and we'll talk about this a little bit more. But it's also appropriate to just stop after 5 years for these patients. If after 5 years that woman has become postmenopausal at that point, there's the option to then switch her to an AI to do another 5 years of that. So total of 10 years, 5 tamoxifen, 5 of an AI, or consider just completing the tamoxifen 10-year course as an option. And then for those patients that may be started initially on OAS and and an AI together, so that's sort of newer data that is an option for patients. So that would be done initially for 5 years. And then patients could be considered to continue that for another 3 to 5 years. So it used to be 5 years, so easy, just tell you 5 years, that's all you need to know. And now it's become a little bit more challenging. But good thing to know here is really that it's anywhere from 5 to 10 years is kind of our time frame now. In a postmenopausal patient, you see a lot of different options. There has been numerous landmark trials in the past that have looked at various combinations of endocrine therapy. The big thing to know here, the most common thing that is done in practice is an AI for 5 to 10 years. And that's the most common thing that's done. But you'll see on here various combinations of tamoxifen and AI. So big thing is that you want these patients that are postmenopausal to get an AI at some point in their therapy. That's what's best. So it could be sequentially with tamoxifen, or it could just be an AI for all of their years. If the patient has a contraindication to an AI, that's where you might consider just doing tamoxifen for either the 5 to 10 year point. But AI preferred for these patients. So where did we get the data from more than 5 years? Since I mentioned that that was a standard for a very long time. The data with the tamoxifen for more than 5 years is based on 2 big trials. So the ATLAS and the ATOM trial that looked at 5 versus 10 years. So ATLAS trial found a reduced risk of recurrence and mortality, benefit in favor of longer courses, of 10-year courses compared to 5, but at the expense of more toxicity. So higher risks of some toxicities that you can see with tamoxifen, rare things, but that can happen. So things like PE and the risk of endometrial cancer that could develop with the use of tamoxifen. In the ATOM trial, similar, reduced risk of recurrence with the long courses. However, it wasn't a reduced risk of mortality. Okay, so not exact same results between these 2 trials. And again, at the expense of more toxicity with more years of tamoxifen. And then there's been some other trials that have shown something different. So it's a little bit of a gray area in practice, hence guidelines saying 5 to 10 years. So for patients, maybe they're having a lot of toxicities, possibly have lower risk disease that don't want to continue. 5 years, I think, is appropriate in what I'm seeing providers doing. For those patients that desire to be more aggressive, maybe had some higher risk features initially, going to the 10 years is a good option. And then AIs. So we mentioned AIs could go up to 10 years as well. So the MA17R trial looked at this. The 5-year disease-free survival was fairly similar. Was in benefit of giving the longer courses. Okay, so the 10 years versus 5 years. But here, no difference in overall survival. So again, why the guidelines give it a consider up to 10 years. And then the newest data here over this past year has been the SALSA trial, which I think is kind of a fun name to say. So the SALSA trial here looked at a different, in saying, can we do something in the middle? So can we do 7 years, okay, instead of going the full 10 years? So the 8-year disease-free survival was very similar in 7 versus 10 years. So more recent data showing us that 10 years, maybe we want more than 5, but maybe we don't need 10. We can kind of land in the middle with 7. So that being an option for patients. Again, guidelines saying consider all of that, but maybe with those higher risk patients, so those with lymph node positive disease, this is where you might want to push them and kind of go the duration if we're able. So looking at adding this together. So we've mentioned OAS as we've gone through this a little bit with our algorithms, and this was based on a combined analysis of the soft and text trials. So pretty complicated trials if you've ever had to read these. So 2 separate trials that they combined the analysis. They weren't the same exact trial, but had similar features of the trial. So these were patients that received something to shut down ovarian production. So either the LHRH agonist, in this case was triptorelin, which I know probably I don't see in my practice, probably a lot of you don't see that, or things that are ablating the ovaries, so oophorectomy or ovarian radiation. And this was either given in combination with tamoxifen or OAS in combination with an AI, and they did this for 5 years in this trial. They didn't do a 10-year course. So disease-free survival, 86.6% in the AI OAS arm, which was a little higher than what we see in the other combination, 82.8% in tamoxifen OAS arm. Guidelines list both of those combinations as appropriate options. You see, based on numbers alone and the statistical significance, maybe a benefit here with the AI OAS combination, but again, guidelines say either of these 2 combinations are appropriate. But higher toxicity. So usually, the more you give, the more toxicities you're going to get. So that's kind of the give and take here. And that's why guidelines say we saw early in the algorithms plus or minus OAS. And it comes in with this kind of higher toxicities. So where you would consider I think more the plus, where you would want to do this, is higher risk patients that have maybe younger age, higher grade tumor or lymph node involvement, specific criteria that's sort of listed out for consideration. Okay. And then really kind of more late-breaking information is the results of the monarch-E trial. Okay, so CDK4/6 inhibitors, probably a lot of you are familiar if you have any exposure to breast cancer treatment. You've heard about these drugs in the metastatic setting, but they have moved their way up more recently to finding a role in the adjuvant therapy setting. So this based on the monarch-E trial, this is adjuvant abemaciclib, CDK4/6 inhibitor, with the addition of endocrine therapy. So large phase 3 trial, this is hormone receptor positive, HER2 negative, early stage breast cancer, but these were patients that were deemed to be high risk. So pretty good prognosis features overall, but did have some higher risk features. Patients had to have had local therapies, so surgery plus or minus radiation, and then also could have received adjuvant or neoadjuvant chemotherapy. And most of those patients did, being high risk. So they were randomized to standard of care endocrine therapy alone for 5 to 10 years that we've been talking about, or the arm that added abemaciclib to this. And they did this abemaciclib for 2 years. So a standard endocrine course of 5 to 10 years with the addition of 2 years of abemaciclib. And they defined high-risk features, and this is where it got a little bit complicated with the analysis. So they considered high-risk features of at least 4 positive lymph nodes, or patients that had 1 to 3 positive lymph nodes but had some other high-risk features, so a larger primary tumor size or a high grade of tumor, so grade 3. And then they added in a second cohort based on the patient's Ki-67, so a marker of cellular proliferation. So the higher the Ki-67, probably the faster growing the tumor is. So they included a cohort that had 1 to 3 positive lymph nodes that had a Ki-67 of at least 20%. So we don't have terribly long follow-up here. So at 27-month follow-up, invasive disease-free survival was improved in the abemaciclib arm, hazard ratio of 0.7, and 3-year disease-free survival was improved as well with the addition of abemaciclib. So based on these results, the FDA approved this combination in the adjuvant setting. So I do want to point out again that this is patients that were deemed at high risk for recurrence. So this is not all adjuvant patients with hormone receptor positive disease. So they have to have some of these high-risk features. And ASCO actually goes along with that recommendation and says that this is possible as well. Little nuances here that FDA actually does include an and a Ki-67. So they're saying that it has to have a Ki-67 of at least 20% plus high-risk features. NCCN guidelines say they could have had some of these high-risk features or this Ki-67. So NCCN guidelines really matching the trial information we saw with both of those cohorts. And ASCO kind of goes along with all of that and saying any of that is fine. Okay, so again, we're going to take it back to a patient case, YC. 37-year-old premenopausal African-American woman presents with newly diagnosed right breast cancer, 1.3 times 1.3 centimeter, so stage 1A, pretty small tumor, lymph node negative. Pathology is listed here. So I want to point out that this patient is triple negative, so ER, PR negative, HER2 negative, high Ki-67. Okay. She has a BRCA2 mutation, no other comorbidities, and she's treated with a radical mastectomy. Okay. So according to NCCN guidelines, which of the following adjuvant chemo regimens is most appropriate for this patient? Is it A, CMF chemotherapy, B, carboplatin, C, dose-dense docetaxel and cyclophosphamide, or AC, followed by paclitaxel, or D, paclitaxel? Okay, so we are moving into our next kind of category of therapies. And great, a lot of you did really well on this question. So most appropriate for this patient is dose-dense AC followed by paclitaxel. She's got triple negative disease, pretty high-risk disease. You wouldn't want to do single-agent chemotherapy for someone that can tolerate more than that. And CMF, we'll talk about, is an option, but probably not the most appropriate option for this patient. Right. Okay, so this is where she fits into our algorithm. So I'm happy to say this is not a new algorithm. This is just showing you where this particular patient YC fits into what we presented earlier. So she has got hormone receptor negative and HER2 negative disease and has a tumor of greater than 1 centimeter. So she fits into just receiving adjuvant chemotherapy, no need for trastuzumab here, no need for endocrine therapy. Okay, so moving on into, we passed through our endocrine therapy, which was a really big category. We're now moving into chemotherapy. Okay. So I wish I could tell you that there is one right answer here, but of course there isn't. There's lots of options for us. So we'll point out kind of what are maybe the more appropriate options on the list. Guidelines really don't address that this is the best, most optimal regimen, but they do kind of call out some preferred regimens. But any of these listed on the slide could be appropriate for patients. So typically what we're looking at here are primarily the preferred regimens. And so those that have the little A asterisk here, and so I'll point those out. It's kind of hard to see, I know, on the slides, at least the handout slides. But those are dose-dense AC followed by paclitaxel. Okay, so that top green box there. And the other preferred regimen by NCCN is TC, so the one right underneath that, and that's docetaxel and cyclophosphamide. So you notice that these are both taxane-containing regimens that are preferred. TC is an anthracycline-sparing regimen. Okay, so that's kind of the big difference between those two preferred is the anthracycline versus no anthracycline. So there are other options here. So there's possibly, you could use something called TAC, really kind of fallen out of favor more recently. Using non-dose dense strategies, which we know don't quite work as well, but they're still options for patients that maybe can't tolerate dose dense therapy. Newer addition of pembrolizumab, which is kind of a really brand new thing in breast cancer that we'll talk about. That's actually, I'll point out, that's another preferred regimen for very kind of specific population that we'll talk about in upcoming slides, but that's another preferred one. You'll notice options for just anthracycline alone without the taxane. These could be considered for patients that maybe aren't taxane candidates, but very rarely do I see these being used without a taxane. And then one of the options that was wrong on the last slide was CMF. So that is a possible chemotherapy regimen, so cyclophosphamide, methotrexate, and fluorouracil. It's an older and a historic regimen, used to be a standard of care, is kind of considered to be a more gentle approach, less toxic regimen. So potentially in a patient that has a lot of comorbidities, that can't handle aggressive chemotherapy, that remains an option for those patients. So what I would consider to be key points here is that a regimen that contains an anthracycline and a taxane, so like most of you selected for our patient, this is generally considered to be a standard of care for patients that have higher risk features. So things like larger primary tumors, lymph node positive, triple negative, like the case of our patient YC. Okay. Other regimens preferred by NCCN, still good options such as TC, can be appropriate for any patients, but maybe more appropriate for the subset of patients that are not really deemed to be anthracycline eligible patients. So maybe poor cardiac function, other comorbidities, elderly patients that may not be candidates for such aggressive chemotherapy. But really need to look at the risk-benefit profile for all patients. Any of the regimens on the last screen can be appropriate options. And there's more detail about all of this in the handout with specifics on dosing, dose-dense versus non-dose-dense strategies. All right, so that was a lot, but that really covers what we need to talk about for our early stage disease. So this primarily stage 1 and 2 patients. We're going to move on to some discussion about patients with locally advanced disease. So this is generally when we're getting into a stage 3 disease for patients. And what you'll see that changes a little bit in our algorithm is we've added something above surgery. So we've added neoadjuvant chemotherapy here. So these are generally patients where it's difficult to take them right to surgery because of size of tumor, desire for patients having a lumpectomy, and so needing to kind of shrink things before we can get to surgical resection. And so this is where you're going to see usually the addition of neoadjuvant therapy. And you'll notice that the HER2 targeting agent then moves up to be started at the time that you start chemotherapy. Okay? And a lot of the other algorithms similar to what we talked about previously. So some key things to think about with neoadjuvant chemotherapy. So the regimens that we spoke about in the adjuvant setting, so our slide that we just went through those boxes of options. Those are generally the same options that we're considering in the neoadjuvant setting. So making it a little bit easier here, you can kind of think across the board adjuvant and neoadjuvant. A few little nuanced things that we'll talk about. For the most part, they're the same. For patients that have hormone receptor positive disease, some of those patients could be considered for endocrine therapy as a neoadjuvant strategy, so not doing chemotherapy as neoadjuvant, but doing endocrine therapy alone. The problem here is that endocrine therapy doesn't work as quickly as chemotherapy. So you kind of have to factor that in, and maybe for a patient that you want to use neoadjuvant therapy, but is not a good candidate for chemotherapy, you can consider doing endocrine therapy up front to try to shrink things prior to taking the patient to surgery. If the patient does receive neoadjuvant treatment, just like we showed in our sequencing slide, if they're hormone receptor positive, you want to start a trastuzumab-containing regimen at the onset of chemotherapy. So right at the time you're starting their initial neoadjuvant, that's when you're going to add that in. And then generally that HER2 targeting agent is going to be continued into the adjuvant setting. And then for the most part, we're going to complete our chemo regimen in the neoadjuvant setting. So again, there's always, in breast cancer, there's always a couple nuances here. But for the most part, for example, doing something for YC like dose-dense AC followed by paclitaxel, you're not going to do dose-dense AC surgery paclitaxel. You're going to give that full course of chemo in the neoadjuvant setting, then surgery, and then kind of reevaluating additional therapy from there. Okay. So there's a lot that's changed with this particular slide over the last couple years. And I'm not going to really dive into this, but point out some of the important things to consider here. So generally, when we're considering patients for neoadjuvant treatment, this is usually a decision the surgeon and the medical oncologist are kind of making together to kind of determine whether go right to surgery or do we need to administer some neoadjuvant therapy. So generally, the good candidates for neoadjuvant therapy are patients that have something called inflammatory breast cancer. It's not very common, but it's a more aggressive form of breast cancer. And generally, those patients are going to get neoadjuvant therapy. Patients with bulky tumors, so large tumor sizes, a lot of lymph nodes, we're going to do that to try to shrink tumor. For those that are hormone receptor positive or triple negative, we now have some good information about the results of neoadjuvant chemo driving some of their adjuvant treatment decision making. So this is kind of where we've had some of those big changes, that you don't necessarily have to have patients with really large tumors or really large lymph node involvement, that you still may want to consider them for neoadjuvant therapy to help guide some of the adjuvant treatment decision making. And NCC and ASCO have a lot of similarities in their recommendations here, so I'm not going to go through in detail, but just to kind of show you where they stand. So we're now going to move on to patient VT. VT is a 58-year-old postmenopausal Caucasian woman diagnosed with a stage 3A invasive ductal carcinoma, our most common type of breast cancer. So pathology is listed here. She's triple negative. She is germline BRCA1 positive. She receives neoadjuvant AC, dose-dense fashion every 2 weeks, followed by weekly paclitaxel for 12 cycles, or 12 weeks. So good candidate based on size of her tumor and being triple negative. So she gets that neoadjuvant treatment. She undergoes breast-conserving surgery, also known as a lumpectomy or partial mastectomy. At the time of surgery, she's found to have residual disease in the breast. Okay, so neoadjuvant treatment did not completely get rid of cancer cells in the breast tissue. So based on this, in addition to radiation, since this patient had a lumpectomy, which adjuvant treatment is most appropriate for this patient? Is it A, adotrastuzumab emtansine, B, TC chemotherapy, C, paclitaxel carboplatin, or D, olaparib? Okay, excellent. So I did not trick you guys. You have a good sense of a patient having a BRCA mutation, one here that we really want to pay attention to. And we'll get to that data in just a little bit. So now we're going to transition. We're going to have some discussion here about patients that got neoadjuvant treatment and surgery, kind of what to do after that. So what do we need to do in the adjuvant setting? So we said for a lot of these patients, radiation is going to be needed, but we're going to look at other systemic therapies that may be an option for a patient. Some of this data is based on the CREATE-X trial, where we get a recommendation for capecitabine in some of our patients. So this is a trial that included patients with anywhere from a stage 1 to a stage 3B that had neoadjuvant chemotherapy up front. Okay, so typically that isn't what's being done in the really early stage, but this trial included all of these patients. So they had neoadjuvant chemo, they had surgery, and then they had residual disease at time of surgery. Okay, so when the surgeon went in there to do their resection, there was still some cancer left in there after the patient had had neoadjuvant chemotherapy. Those patients were then randomized to adjuvant capecitabine, so giving more chemotherapy in the adjuvant setting for 6 to 8 cycles, or the control arm, which was no chemotherapy, which was standard of care. Okay, so we knew these patients were at higher risk because they had residual disease, but there wasn't really anything that we did about it. It was really just observation, standard of care. So at 5-year follow-up with the CREATE-X results, disease-free survival, which is the primary endpoint, was improved in the group that received capecitabine, statistically significant result, and disease-free survival was also longer in that group. So in particular, in the subgroup with triple-negative disease, that is the patient population that had the most benefit. So disease-free and overall survivals that were improved in this subgroup compared to the overall all-comer patients. And so based on that subgroup analysis, both NCCN and ASCO agree here that that is the patient population that should be considered for adjuvant capecitabine, patients that have triple-negative disease that had residual disease after their neoadjuvant chemo. Okay, so a very specific subgroup of patients to consider this. So one thing I'd like to point out here is that the dosing that was used is a pretty high dose of capecitabine. I don't know about you guys, but it's really difficult to get patients through with this dose. And so the guidelines make note of that and say, especially in kind of the Western world where we have fortified diets, that you really should be considering a lower dose. So kind of standard for what's done most of the time now is 1,000 milligram per meter squared for these patients, the days 1 through 14 every 21 days for that 6 to 8 cycles. So generally a lower dose. Pretty high toxicity rate in this trial with that higher dose. Okay, so now we're going to move on with our schematic here. We've gotten through endocrine therapy and chemotherapy. We're going to now move on to just a little bit of data that's really made some waves in the breast cancer world with adding immunotherapy. So we're slow to do that in breast cancer and really didn't have anything in the early stage setting until just recently, and we have one trial to point to that people were pretty excited about. So the KEYNOTE-522 trial. So phase 3, large trial, patients with stage 2 or 3 triple-negative breast cancer. Okay, so they did not include stage 1, and these patients were all triple-negative breast cancer. So patients were randomized to neoadjuvant chemotherapy alone or chemo plus pembrolizumab. They then went on to surgery, and for those patients that got pembrolizumab arm, so those that got neoadjuvant pembrolizumab went on to 9 cycles of adjuvant pembrolizumab after surgery. For those patients randomized to non-pembro arm, so the placebo arm, they went on to just placebo adjuvant therapy. And you can see the neoadjuvant regimen listed here. So pretty aggressive chemotherapy. So these patients actually got paclitaxel carboplatin, okay, followed by AC, every 3-week AC in the trial. So this was not a dose-dense AC. I just point that out. So that was the neoadjuvant. So pretty aggressive chemotherapy up front with a dual primary endpoint of pathologic complete response, so a surrogate marker for long-term survival in breast cancer, and then event-free survival. So results here, the primary analysis was just with PCR rates, so pathologic complete response, which was in favor of the pembrolizumab group. So an absolute difference of 13.6% with the addition of pembrolizumab here. And then we had follow-up at almost 38-month follow-up here, which this was really what drove some of the clinical guideline decision making. So people were really hesitant to just make some changes based on PCR. But when we had the the EFS results, this is really when this kind of changed things and led to FDA approval of this regimen. So statistically significant improvement with a hazard ratio of 0.63 with the addition of pembrolizumab to neoadjuvant therapy and then continued in the adjuvant setting. So NCCN guidelines recommend this based on that patient population of the trial, so stage 2 or 3 triple negative patient. Okay. So olaparib here. So we have a little bit of data we continue to add options in this setting. So there's really one major trial we'll talk about here with the addition of olaparib, and that was our patient case that we talked through. And I'd like to highlight that this is in the adjuvant setting only, so we do not have good neoadjuvant data for olaparib at this point. So this is based on the Olympia trial. It was a large phase 3 double-blind trial. This was patients that had BRCA1/2 germline pathologic or likely pathologic variant. So just to point out that this is, again, a very specific population, BRCA1/2 germline mutations. So they did not include any patients with somatic mutations of BRCA. These patients had high-risk clinical pathologic features and had received local treatment and neoadjuvant or adjuvant chemo. So had kind of had the standard of care approach, surgery plus or minus radiation and chemotherapy. These patients were then randomized to either olaparib for 52 weeks or placebo for 52 weeks. And then we looked at invasive disease-free survival was their endpoint. So you can see the 3-year data is what we have right now. So almost 86% in the olaparib group versus 77% in the placebo group, hazard ratio of 0.58. So practice-changing result for these patients. And distant disease-free survival, you can see also improved in the olaparib arm. And the one grade 3 adverse effect to watch out that was more common in the olaparib arm was anemia. So certainly something that we know about with the PARP inhibitors. But generally a well-tolerated regimen. And so these are really just kind of memorization things. This is based on the trial patient population, is what we got for recommendations in guidelines based on this. So both ASCO and NCCN guidelines here. So specifically looking at using this agent, adjuvant olaparib, after neoadjuvant chemotherapy. Guidelines recommend this for 1 year of adjuvant olaparib. This is going to be after the completion of neoadjuvant chemo and local therapies, so even this would follow after radiation. Okay, so it interacts with radiation, so you'd want to complete a radiation course, then olaparib for these patients if they've had triple negative breast cancer and residual disease after their neoadjuvant therapy, so a higher risk patient population, just like the one in the CREATE-X trial. Or patients that have hormone receptor positive HER2 negative disease with residual disease that have some higher risk features that are listed here. So have to have this score that's greater than or equal to 3 with this grading score. Again, it's recommended to give all of our upfront therapy that we've been talking about, so all of our chemotherapy, all of our radiation surgery, all of that, and then this olaparib would follow the completion of that. And you'd want to radiation would need to be done at least 2 weeks prior to the initiation. You can do olaparib with endocrine therapy. So if you have a patient with hormone receptor positive disease, you can do those two together, but basically you don't want to do it with anything else in combination, concurrent. And then in the adjuvant setting, so slightly different here. So again, recommendations for 1 year for patients triple negative breast cancer if they have very specific criteria that are listed here. So residual disease, or these patients that have particular T2N1 disease. For those patients hormone receptor positive, HER2 negative, and have at least 4 lymph nodes, these are patients that you would consider if they have the criteria that's listed on the slide. So very specific criteria in the setting. Makes it kind of difficult, I would say, overall to kind of memorize all of this. So we'll see where it lands up. We just have this one Olympia trial. None of the other PARP inhibitors have been studied in this setting. So I think we'll continue to see changes with this. So our patient case, HF, this is a 60-year-old female, minimal comorbidities, newly diagnosed stage 3B, so very large T4 tumor, left breast cancer, pathology ER positive, PR negative, HER2 3+, plans for lumpectomy followed by radiation. So what would be the most appropriate neoadjuvant regimen for this patient? She's postmenopausal, stage 3B, ER positive, PR negative, HER2 positive. Is it A, AC plus trastuzumab for 4 cycles, B, docetaxel, trastuzumab, and pertuzumab for 6 cycles, C, TCH plus pertuzumab times 6 cycles, D, AC for 4 cycles, followed by paclitaxel weekly for 12. Okay, nice job. You guys are really impressing me today. So TCH plus pertuzumab, or TCHP, for 6 cycles is the best neoadjuvant option for this patient. So A is wrong because you do not want to give trastuzumab in combination with an anthracycline at the same time. Okay, so exponentially higher cardiac toxicity given those two concurrent. B is an option that has been studied, however, better option in the metastatic setting. So you will not find this option listed in the patients that are curative intent in the neoadjuvant setting. And then D, kind of pretty obviously wrong here, I think, because of the fact that this patient's HER2 positive and you don't see any HER2 targeting drug here. Okay, so we're moving right on to our next question, keeping you guys on your toes. Wow. Which of the following is the most appropriate adjuvant HER2 targeting agent for HF? Is it A, pertuzumab, B, trastuzumab emtansine, C, trastuzumab plus pertuzumab, or D, neratinib? Okay, excellent job. So she had TCHP in the neoadjuvant setting. So A is wrong because you would never do monotherapy pertuzumab. Okay? If pertuzumab is going to be given, it has to be given with trastuzumab. B is not correct here. So this patient, there are potentially some considerations. We certainly use this drug in the adjuvant setting, but it would be for a patient that had residual disease that we'll talk about. And then D, neratinib would not be appropriate as the primary adjuvant HER2 targeting agent. So there is a very specific role for this drug that we'll talk about. Okay, so we're now going to move on to that HER2 targeting setting. So this is just a sort of a high-level summary slide for the drugs that we have in this setting, both adjuvant and neoadjuvant setting, and we're going to talk through some of these in a bit more detail. Some of the newer things to add is we now have sub-Q options, which may be helpful to some of our patients, both a trastuzumab sub-Q and a combination trastuzumab-pertuzumab sub-Q option. So both of those exist. And then just to kind of point out a couple things here as well, the last 2 bullets. So we'll talk about trastuzumab emtansine. You see here just adjuvant, so there was no neoadjuvant data with this one. And then neratinib, that was an option, an incorrect option on our last slide, could be considered in select patients in the extended adjuvant setting. So beyond the normal HER2 targeting course, some patients may get this additionally. Our primary agents we're talking about are trastuzumab and pertuzumab. So those are the ones that have been around for the longest in this category. Trastuzumab is recommended for all HER2 positive patients in general, but primarily the literature is in those patients that have a greater than 1 centimeter tumor. So all of the major trials were done in that setting. So that's where it kind of gets its primary recommendation. But you could consider it in some patients with smaller than 1 centimeter tumors. Pertuzumab can be added to trastuzumab. We said we wouldn't do it by itself, but it could be added for patients, primarily those patients that have tumors that are greater than 2 centimeters, so slightly larger tumors, where you would consider adding this, as well as probably the primary population here being patients with lymph node positive disease, where you'd want to be more aggressive in adding pertuzumab to trastuzumab. And usually you're going to do this in combination with their chemotherapy. You said the exception of that is the anthracycline that you would want to give sequentially versus concurrently. So the standard of care is 1 year of HER2 targeted therapy. And we mentioned pertuzumab alone. If you've ever see that as an option on any exam, that is never going to be the correct option. It's always going to be given in combination with trastuzumab. So just like our non-HER2 regimens, here is a slide with our HER2 targeting regimens. So chemotherapy plus HER2 targeting agents. And you can see broken down, so the left side of the screen here is the preferred regimens that we're going to focus on today. So options here being what we consider for our patients, so TCHP, so adding pertuzumab. We said preferentially for those patients with lymph node positive disease or tumors that are more than 2 centimeters. TCH without the pertuzumab is also an option here. And then for patients that have low risk, smaller tumors, no lymph node involvement, potentially these are patients that are candidates for weekly paclitaxel with the addition of trastuzumab. So a more gentle chemotherapy regimen for those patients that maybe don't need the aggressive regimens. And then we have a number of other options you see listed on the screen with various chemotherapy, anthracycline, non-anthracycline containing regimens. So very quickly, a summary of pertuzumab in the neoadjuvant setting. So for pertuzumab first made some waves in the metastatic setting. That was really where it generated a lot of excitement, and it has moved in earlier lines of therapy to the neoadjuvant setting based on the NEOSPHERE and TRIFINA trials. So NEOSPHERE was looking at a regimen we actually don't use. So it was pertuzumab, trastuzumab, and docetaxel. We do not use that in the neoadjuvant setting in the United States. We add other drugs to this. So we add carboplatin usually to this, which was actually not a part of this trial initially, but they looked at pertuzumab, adding pertuzumab to the backbone versus not, and there was a statistically significant improvement in PCR, which was a surrogate marker for survival in these patients, that we really opened the door to using it earlier on. And then we have the TRIFINA trial, which, just to point out, this was actually not designed as an efficacy trial, it was designed as a cardiac safety trial. So a little bit interesting in that way, but it's really where we have our data to give AC followed by a taxane plus pertuzumab and trastuzumab, and also where we got some information about TCHP, which is really one of the primary regimens that we're using here, and it comes from a cardiac safety trial. So just a quick mention for the sub-Q formulation. So in particular, just a little bit with the combination of pertuzumab, trastuzumab, and hyaluronidase. So just to point out here, it does require a loading dose followed by the maintenance dose. It's given in the thigh, so loading dose over 8 minutes, maintenance doses over 5 minutes. How many of you are using sub-Q in your practice? Okay, we have a decent number of hands, so maybe about 10 people. So I think it can be a really good option, especially in the maintenance setting for a patient maybe that doesn't want to have a central line. You have options, pretty quick administration for these patients over, typically 5 minutes. We've talked a lot about residual disease. So specifically with HER2 targeting therapy. So we said in triple negative, we have the CREATE-X and we have capecitabine. Okay? So for patients with HER2 positive disease, if they have no residual disease after neoadjuvant, so they get their neoadjuvant chemo, they go to surgery, cancer's gone, nothing there. Then the plan for most patients is trastuzumab plus or minus pertuzumab for 1 year, total, complete 1 year of therapy, and then they're done. For patients that have residual disease at time of surgery, this is where we use trastuzumab emtansine. Okay? So for those patients, we know they're higher risk for recurrence, so we're using antibody drug conjugate in these patients for 14 cycles. And this is based on the Catherine trial. So HER2 positive patients here that received neoadjuvant chemotherapy and had residual disease were randomized to either trastuzumab emtansine for 14 cycles or standard of care at that time, which was trastuzumab for 14 cycles. And this was really impressive results. You see an invasive disease-free survival hazard ratio of 0.5, so a 50% improvement in invasive disease-free survival with this using trastuzumab emtansine, which was really huge here. Still don't have overall survival benefit at this time, but waiting for more mature results of this trial. And this was consistent across all subgroups. So really landed, based on the Catherine result, patients have residual disease, that's the way to go. The Affinity trial was looking at adjuvant pertuzumab. So we talked about the data in neoadjuvant with NEOSPHERE and the TRIFINA trial using it in neoadjuvant setting. But what about continuing it in the adjuvant setting? So it's in guidelines. People were really excited about some great data in the neoadjuvant setting, and it was really lackluster results, to say the most, in terms of using it in the adjuvant setting, but it's still something that's pretty routinely done in practice. Here they looked at trastuzumab, pertuzumab for a year versus trastuzumab and placebo for a year in these patients. And what they found really was not a big difference in invasive disease-free survival at 3 years, so 94.1% versus 93.2%, which really not a big difference in this patient population. So that was all patients. But specifically looking at the patients that were lymph node positive, that's where it had more of a benefit. And so that's why we've kind of been emphasizing those patients that are lymph node positive in the guidelines are really the patient population where you would consider adding pertuzumab to their therapy. So at 6-year follow-up, no difference in overall survival with the addition of pertuzumab. So really guideline-wise, you'll see it say a lot of plus minus. It's a consideration, but not an absolute. And then finally, just to mention the Extenet trial. So this is looking at extended adjuvant therapy. So we've talked about generally a year total of HER2 targeting therapy. So is more better? If we go beyond a year, is that better? So this was a trial that looked at an oral agent, neratinib, for a year after they had already had their year of HER2 targeting therapy. And they did this versus placebo, which would have, standard of care was not to do anymore. So you see here in the disease-free survival events, there were fewer disease-free survival rates events in the group that had neratinib, or hazard ratio of 0.73, so statistically significant result. Interestingly, this was more benefit in patients that were also hormone receptor positive. So that seems to be the kind of niche population, hormone receptor positive, HER2 positive. You could consider doing more, giving neratinib beyond. No overall survival benefit here, and I would say in practice, I do not see this done very often. Neratinib has plenty of toxicity for a lot of patients, so it really has to be a patient that's really desires additional therapy and maybe meets these hormone receptor positive, maybe more aggressive disease where you want to give them more. Diarrhea is a big problem, and that's why we mentioned it's very difficult to tolerate. Most patients develop diarrhea, and high-grade diarrhea in 40% of patients. So some interesting data that's come out on this. So really we have a couple different options. You can use anti-diarrheal prophylaxis scheduled for patients. So you can do that for the first 2 cycles or about 2 months of therapy, where you don't give it to them just PRN, have it in case. You actually schedule. They take it on a schedule for those first 2 cycles, and that's really well detailed in the PI. The newer option here is that patients are eligible for a dose escalation strategy based on the control trial. So these patients had a lot lower risk of diarrhea if it's done this way. So starting at 120 milligrams for week 1, then up to 160, and then up to the full dose of 240 starting at week 3. So that's really what I'm seeing done in practice, both, mainly seeing this used in the metastatic setting, and that's what we're doing. You could also consider adding loperamide prophylaxis to that, but the trial actually didn't do both of those together. So you really could do the dose escalation by itself with PRN loperamide, or you could just do straight 240 dose if you are feeling aggressive, and then adding the antidiarrheal prophylaxis. Okay. And very last thing I want to mention in this early stage setting is the use of adjuvant bisphosphonates. So that is an option. I personally don't see it very much in my practice, but I want to point out a couple things. It is an option just in a postmenopausal patient. So that's primarily where we're seeing these benefits of using bisphosphonates, so something like zoledronic acid. And so we're not talking about treating bone mets. We're talking about benefits to decreasing the risk of breast cancer recurrence for these patients. So it's modest benefits overall, but could be considered in patients that are postmenopausal. Usually this is the 4 milligrams every 6 months of zoledronic acid for anywhere from 3 to 5 years. And just more recently, guidelines have updated to say, yes, you can do this, but you really should be doing it in patients that are higher risk. So high risk node negative or in lymph node positive patients is where this might have a role. So I want to wrap up this kind of section by talking a little bit about cardiotoxicity. We're going to go back to our patient HF, received TCHP for 6 cycles, followed by surgery, and then adjuvant ado-trastuzumab emtansine for 14 cycles. So this patient, according to pertuzumab's prescribing information, what is the most appropriate frequency for monitoring her LVEF, left ventricular ejection fraction, during neoadjuvant therapy following baseline assessment? A, every 12 weeks, B, every 6 months, C, every 6 weeks, or D, every 2 months? Excellent. So every 12 weeks based on pertuzumab prescribing information. We're going to jump right into the next one. While receiving her adjuvant trastuzumab or pertuzumab, her LVEF decreased from a baseline of 60 all the way down to 49. So a pretty concerning drop there via MUGA scan, and this is done checked prior to cycle 12. What is the most appropriate action at this time? Would you continue the combination? Would you hold trastuzumab and pertuzumab? Would you restart trastuzumab but discontinue the pertuzumab? Or would you restart the pertuzumab but discontinue the trastuzumab? Okay, excellent. So majority of you chose the correct answer. At this point, we would be holding both of those drugs based on what's in the prescribing information that we'll get to. C, there really isn't a recommendation. The pertuzumab, even though both are cardiotoxic drugs, studies really haven't shown that pertuzumab adds anything to the cardiotoxicity. So generally, if you're going to hold one, you're going to hold the other one as well. And then D is also just wrong because we said we would never do pertuzumab monotherapy. So cardiac monitoring, and this unfortunately is just some straight kind of memorization of what to do here. Generally, for these patients receiving trastuzumab, they need to have a baseline assessment. So this is kind of history. And then also we want to have baseline ejection fraction, either by a MUGA or an echo scan. So either is acceptable, but as you choose one of those and monitor the patient throughout therapy, you really want to try to stick with the same test. So if you started with echo, which is what I tend to see in practice, then continuing an echo with your additional assessments versus if you start with MUGA, continuing with MUGA. And that's because they're two different tests that can give two different results. So it's comparing apples to oranges, which is really difficult to do. So sometimes I have seen in practice where you're comparing the two, you have two very different results, and you don't have a good way to move forward with what to do with those results. So best thing to do is when you are comparing echo to echo or MUGA to MUGA. So you want to have an evaluation of that prior to therapy, so a baseline, every 3 months during and at the completion of trastuzumab. And then the PI recommends that you even do this every 6 months for 2 years beyond completion of trastuzumab. I don't know if I should be saying this, but I don't see that done in practice very often, but that's technically PI recommendations, is that even after therapy is done with your trastuzumab, you continue beyond for 2 years. Recommendation to hold trastuzumab for at least 4 weeks if patients have had either an absolute decrease in LVEF between your assessments of 16% or more, so that's a pretty decent drop, or patients' LVEF is below the institutional level of normal, and at least a 10% or greater drop in their LVEF from pre-treatment values. So if patients meet either one of those two criteria, it's recommended to hold for at least 4 weeks and then reassess. If it returns to normal levels, you can continue the drug. You wouldn't do any sort of dose reduction or anything. You just resume the drug. But if it does not, then generally at that point, you're continuing to hold and continuing to reassess. For patients that are receiving those combination of pertuzumab and trastuzumab, the pertuzumab PI is pretty specific here. It's slightly different. So the recommendation for monitoring is baseline and every 12 weeks, as you guys appropriately selected for our patient. And then you would hold both of those drugs for at least 3 weeks if either of these criteria is met. So here's where they have a little bit of nuance difference as well. So difference in the metastatic setting versus using it in the neoadjuvant or adjuvant setting. If it's metastatic setting, they allow for a lower LVEF before you would consider holding the drug. So they let less than 40%, or if it's 40 to 45%, that at least a 10% percentage drop in your compared to your pretreatment value. And then in the neoadjuvant adjuvant setting, they say if the LVEF is less than 50%, so we're more conservative here, with a fall of at least 10 percentage points from your pretreatment value. That's when you would want to hold and reassess. And then, of course, anthracycline cardiotoxicity. So we have to mention this as part of a cardiotoxicity discussion here. A couple core things to talk about is that there's different types of anthracycline cardiotoxicity. So really lump in 3 different categories. You have acute, you have your chronic, and you have a late onset. So acute is relatively uncommon, generally transient, may not even be picked up. It's not related to cumulative dose. So it's not the one that we're usually talking about with anthracyclines. Chronic is more what we're usually talking about. So this is, can be progressive, can be life-threatening for patients, and this is the one that's generally related to the cumulative dose of anthracycline. And then we have late onset, which is certainly a concern when we talk about pediatric protocols and long-term adverse effects. So pediatric cardiotoxicity with use of anthracyclines is probably more what we're talking about here, and this can develop decades after treatment, so very late onset. Risk factors are listed here, so things that you would expect. So cardiovascular risk factors, hypertension, dyslipidemia, patients that are over the age of 65, those that have a low to normal baseline LVEF, and then certainly with anthracyclines, we're talking about cumulative toxicity, cardiotoxicity in most cases. And so just listing here where we talk a little bit of a table, I'm sure most of you have seen this at some point, with risk of toxicity, and really where we see it exponentially increase is where we get beyond 450 milligram per meter squared as that cumulative lifetime dose. So going between 450 and 600, you see a pretty rapid exponential increase. And so generally most people are kind of considering, once you get to that 450, sometimes pushing up to 550, kind of your max dose, and a lot of discussion pushing beyond that with risk of toxicity. And then to add, there was some discussion earlier about dexrazoxane from an extravasation perspective. So there's a bit here about using its secondary prevention for cardiotoxicity. So sort of older data, guideline update has not happened in a long time, but there is recommendations to consider the use in patients specifically metastatic breast cancer because of concerns potentially it could be affecting efficacy of treatment, so you don't want to use it early stage. But in the metastatic setting, for patients that have received 300 milligram per meter squared IV bolus doxorubicin or equivalent. Dosing here, usually a 10-to-1 ratio between the dexrazoxane and your doxorubicin, and you want to give it right before your doxorubicin. So generally within that half an hour before you're giving doxorubicin, you're giving your dexrazoxane, which I have found sometimes challenging in certain patients with the volume you're trying to get in pretty quickly. And then so there's some recommendations out there with epirubicin that maybe you could also use a 10-to-1 ratio, though most of the data is with doxorubicin.